Bismillah ar-Rahman Rahim. Assalamu alaikum. Dear colleagues and PGs, today we shall discuss the challenges in the management of decompensated liver cirrhotic patients. This discussion has got three parts. In the first part, we shall discuss what is the decompensated patients, and the second part we shall discuss how we should manage a decompensated patients, and in the third part we shall discuss what are the challenges in treating a decompensated patients and how to overcome these challenges. So as I said that the title for today's discussion is challenges in the management of decompensated liver patient. We shall, as I said, the first part is that of the decompensated liver cirrhotic patients. In the second part, we shall discuss how to manage a decompensated liver patient. And in the third part, we shall discuss what are the challenges and how to overcome these challenges. So I'll start with a case history. A 47 years old man who presented with recurrent episodes of hematemesis and melena for one day. He was drowsy, pulse was 110, blood pressure was 90/50, temperature 102, and mildly jaundiced. Past history of cholecystectomy 13 years ago when he was found to be NTHCV positive by ELISA. He is diabetic and hypertensive and goes to his doctors whenever any problem arises. His previous medical record shows mildly coarse echo pattern of his liver with mild splenomegaly on ultrasound done at the time of his cholecystectomy. When his cholecystectomy was planned at that time, this was the ultrasound findings. His PCR has never been checked. So this is a 13 years old ultrasound and was found to be HCV positive, but PCR has never been checked. On examination, he is comatose, jaundice, anemic man with clinically moderate ascites. Abdominal ultrasound is showing, which has been done now, small shrunken liver, dilated portal vein, splenomegaly of 18 centimeter, splenic varices, moderate ascites, and 3.4 centimeter space occupying lesion in his right lobe of the liver. He was admitted to HDO. Protocol of a comatose patient initiated. He was stabilized hemodynamically and started an IV broad spectrum antibiotics. Terlipressin with a close cardiac monitoring for any possible ischemia, ensured proper bowel emptying, and transfused 2 units of packed sol volume. Next day, EGD was done and it showed 3 columns of moderate to large sized esophageal varices with EGV1. No active bleeding, but esophageal varices were showing ERS. EVBL was done. Patients stabilized over next 8 days. He was discharged on diuretics, carvedilol, lactulose, rifaximin, and oral antibiotics. He was advised to come after 4 weeks for follow-up visit. So this is a case history, and I'm sure it's a case history of you come across such patients very frequently in your hospitals, outdoors, in your clinics, that a patient presents as the complications, the hematemesis melena or hydrocytes, and when you probe into the history, the patient was not diagnosed as cirrhotic, but he or she at times is found that was found to be BRC positive, but no proper workup is done and no viral status is checked in most of the cases. And when they present to us with a such sort of a picture. And this is what we do, that we stabilize the patients and when we treat whatever it has been done. So, on the basis of this case history, we shall proceed now, and we shall see what is a decompensated cirrhotic patient, and what should be the management of such patients, and what are the challenges in treating such cirrhotic patients in our setup, and how to overcome these challenges. So the first part, which is the decompensated liver patient. So in this history, let's see that why we say that our patient is decompensated. He has presented with hematemesis in melena. He is drowsy. He has got moderate ascites, and he has got space occupying lesion. And when endoscopy is done, the patient was having esophageal varices with EGV1, and esophageal varices were showing esophageal ERS, endoscopic red signs. So at the presentation, the one sign, the one decompensation is the development of esophageal varices and the rupture. And the second was, of course, the moderate ascites. So if a cirrhotic patient, I have told you that a cirrhotic patient, when the patient develops either the variceal bleeding or the patient develops ascites, these two are the events which make a patient decompensated, which makes the definition of decompensation is either the patient developing variceal bleeding or the patient developing ascites. And the bleeding was confirmed that it is because of the esophageal varices, because of the portal hypertension. And this space occupying lesion, this is the complication which a decompensated patient develops. So this is the decompensated patients. Let's go to some basics. Uh, Either because of the viral diseases like hepatitis B, hepatitis C, or hepatitis D, or the non-viral causes like uh, NASH or alcoholic liver disease, or primary biliary cirrhosis, hemochromatosis, autoimmune hepatitis, whatever the cause may be, when a liver becomes cirrhotic, there is altered anatomy and loss of functions. We all know that. And we know that cirrhosis is a lifelong disease. It's gradually worsening. It's associated with a lot of complications. It's a lethal disease. It takes away the patient unless and until you do something. So the chronic liver disease, either this is the early chronic liver disease when there is no cirrhosis, or advanced chronic liver disease, which we call cirrhosis. And the cirrhosis is again of having two types. The initially it is compensated, and then it becomes decompensated. By compensated cirrhosis, we mean when there are no varices or no ascites, and this is the stage 1. And in stage 2 of the compensated cirrhosis, there are varices, but there is no ascites. But once the patient develops variceal bleeding or ascites, the patient has entered the stage of decompensated cirrhosis. So it is just possible that a patient goes through these progressive stages, like patient is initially non-cirrhotic, then develops, goes into a stage 1 of the compensated cirrhosis, then stage 2 of the compensated cirrhosis, when the patient develops varices, and then the varices bleed, and this is a decompensated cirrhosis. Or the patient has got varices, but the patient develops ascites. It may be that some of the patients who become cirrhotic in stage 1 when no varices and no ascites, but they may develop directly the ascites, and if they develop ascites, they will jump from stage 1 to this stage 3. And why it is so? This is important because if the patient is in the compensated stage, the survival is really different or better if the patient is in decompensated. If a patient is in the compensated cirrhotic stage, the survival is 10 years plus. But if the patient decompensates either by developing ascites or by developing variceal bleed, the survival is decreased to 2 years. But when the patient develops terminal stage, patient goes into the terminal stage, then this patient has got only 2 months survival. So this is very important. And we should be trying to keep these patients in the compensated stage. This is important. So what are the complications? We all know cirrhotic patients, they can develop hepatic encephalopathy starting from above, variceal bleed, ascites, the hepatocellular carcinomas, the infections, the coagulopathy, and the malnutrition. These are the stages when the ascites becomes spontaneous brittle peritonitis or develops becomes refractory or develops hepatorenal syndrome, or the patient's develops tumor which is an extensive one, or if the patient develops acute and chronic liver failure. These are the three main conditions related to the HCC, ACLF, and ascites. When these develops, the patient is in the terminal stage. And now, as I said, that the survival is around 2 months or less. So this is very, very important. So, and unless we do the liver transplant in these patients, the patient is going to die. So, by decompensation, we means if a patient has developed ascites, or patient has bled from the esophageal viruses, this is a decompensation stage. Now, if the patient develops ACLF or the invasive tumors, or the ascites has become either spontaneous brittle peritonitis, or it has developed HRS, or the developed refractory ascites, then this is a stage when it's a terminal one. So, uh, if a patient has presented with some of the decompensation, we should be managing it accordingly, because the decompensation management is different from the one when the patient is not decompensated, it's just a cirrhotic uncompensated one. In the next part, we shall discuss that what is the management of a decompensated liver cirrhotic patients. Thank you.